this will be a shorter lecture, but the way this lecture is framed is really going through why we do lung cancer screening. And I'm just waiting for it to come down from the cloud. Why we do lung cancer screening, but it's also really phrased in the way why we do any kind of cancer screening. So this is kind of a base lecture that I use to go through the whole idea of screening, but really, obviously, it's all about lung cancer screening, because the idea behind any kind of screening within oncology is for what's called stage migration, or you're not trying to find irrelevant cases of cancer, you're trying to find cancer early. Breast cancer and prostate cancer both have struggled largely from the whole notion, and there was even a paper in the New England Journal of Medicine out of the Nordic countries talking about how screening for breast cancer, for example, might not be completely valid because you're finding cases that, can you see my screen? Alisher, can you see my screen?
No. Please share it again.
Okay, so that there may be that you're finding cases that you've disabled my ability to share my screen.
I will ask the administrator.
So there may be cases with breast cancer because, again, this paper came out in like 2015 in the New England Journal of Medicine, saying that there are some cases of breast cancer that may never have been clinically relevant, and because you're not changing necessarily mortality with screening when you find a super small ERP or positive HER2 negative breast cancer in a 75-year-old, for example. Also, like if you think about prostate cancer, there's the landmark study looking at people with that was again published in the New England Journal of Medicine, looking at people who have prostate cancer, where again, I can't share my screen. Prostate cancer who have Gleason score 6 prostate cancer, right? Gentlemen with that.
I'm sorry, please try again to share your screen. And the administrator will allow you.
Tried for the 5th time, it's still not allowing me to do it. I tried again and again, it's not working. But for prostate cancer, right, so you have a large randomized trial looking at gentlemen with Gleason's grade 6 prostate cancer who are randomized to either surgery, radiation, or observation, and they were followed for 15 years, and there's no difference in survival. So in contrast with lung cancer screening.
The professor, maybe you send the presentation to me and we can share it, or please try again.
I just tried again.
Okay.
It's not working.
Host. Maybe the best option will be you will send it to me and I will manage it here.
This is host disabled participant screen sharing.
Okay, I will ask him. So please send it to me on my email and I will ask him to share the screen. Извиняемся за технические неполадки. Сейчас он перешлет презентацию нам, и мы отсюда попробуем делиться экраном. Have you sent it to me?
I'm doing it right now. It's having to upload.
Okay.
I recently had someone hack my computer
Mm.
and take my desktop, which I think was actually my ex-wife. I cannot upload it through my email.
Mm.
It won't let me attach it and get to my, because she messed with. So there's no way to let me share my screen?
Mm. The technical team told that you can share, but we cannot see.
Okay. We'll have to reschedule then because I can't get it to go.
Mm.
So I don't know why I could not share my screen. That
Mm.
I've done this dozens of times. So,
But so maybe you just tell about 10 minutes or 5 minutes about the screening, and the next time we can proceed it.
no,
Because
the whole point of this
Mm.
is of this presentation though is it's very visual because
Mm.
it's going through the whole way that you do stage migration.
Mm.
Because it's like I was trying to lay out, as I was trying to lay out by talking about prostate cancer and breast cancer, about how there's argument whether or not stage migration saves lives. And lung cancer is extremely clear that stage migration saves lives. But that's a very visual thing. And I don't know why I could not share my screen, why the technical team can't tell you why I can't share my screen.
Maybe you try again, and
I will try again. Yeah, the picture's even gone to be able to do it. So we'll have to reschedule to a time where I can actually share my screen because it doesn't make sense for me to.
So maybe I will announce that we will reschedule your lecture.
So, and then, hold on. Can you see it
Oh,
now?
oh, yeah. Everything is okay now.
Okay. All right. So you can actually see it now?
Yes.
Okay. Anyway, so like I was saying, there is with prostate cancer and with breast cancer, there's a whole argument about there's an argument about screening, right? So where with prostate cancer, gentlemen with Gleason's grade 6 prostate cancer who were randomized to either surgery, observation, or radiation actually had the same overall survival at 15 years. There's a difference in cancer-free survival, but not in overall survival. And again, there's this argument that was in the New England Journal of Medicine out of the Nordic countries talking about women who have small breast cancers, whether or not we're basically diagnosing irrelevant cancers. Again, the same argument in prostate cancer as I had just made, which is incredibly different though from lung cancer. As all of us, I think on this call, take care of lung cancer, I don't know that any of us have ever seen an irrelevant lung cancer. And as oncologists, we've all seen irrelevant prostate cancers. So really out of this, what has developed is the whole idea of lung cancer screening. This is the current NCCN guidelines. This is what we use for screening in the United States, or the NCCN rather is the National Comprehensive Cancer Network, which I'm sure you're all familiar with, which is the large organization in the United States that sets essentially the rules or the very strong guidelines for how we are to manage cancer, screen for cancer, et cetera, within the United States. This is actually what binds us legally. So if we don't follow these, we can get sued. And they also bind us based on insurance, what insurance will pay for. So this basically tells us what we can and what we should do. So that's what the NCCN is. Nevertheless, so again, none of us have really seen non-important lung cancer, I don't believe. So the current idea in the US now is that we screen for lung cancer. Anyone who's over age 50, who's had 20 pack years of smoking, over 20 pack year history of smoking, which is, as you know, you calculate pack years by how many packs did you smoke per day. So if you smoked 1 pack per day for a year, you have 1 pack year. And also please recognize that almost everyone says they started smoking 20 years ago, even if they started smoking when they were 5, which I actually have patients who started smoking when they were 5, or if they started smoking at 55. So at least in the US, there's a big tendency to underestimate how much you've actually smoked. So what we will do though is anyone who smoked for over 20 pack years or 1 pack per day on average for 20 years and are over age 50 will perform a low dose screening CT on them annually. We will talk to them about the risks and benefits of doing that, but we will largely and very strongly recommend doing this. And this is based on the data that I'm about to show you, but this is again the NCCN guidelines from January of this year, again, recodifying that for us. And where does this come from? This comes from a study that was originally published in 2011 in the New England Journal of Medicine, which looked at people who were randomized, actually about 50,000 people who were randomized to either low-dose CT scan or a chest x-ray as lung cancer screening. Half the patients were former smokers and half the patients were current smokers. The slight majority were men over women. And then you can see the age at randomization was basically between age 55 and 74. For a long time, the guidelines were actually to only screen people between 55 and 74 based on this study, but they've been recently liberalized to also include people who are younger, and they've brought it down to 50. Again, this is looking at 50,000, literally 50,000 or 52,000 former smokers and smokers, current smokers. And looking at chest x-ray versus chest CT, this is then looking at over a 3-year period what you found. So looking at total number of people screened, obviously it was again right around the 50,000, so there's very, very little drop off. There was a lot higher rate of quote unquote a positive result in the low dose CT versus chest x-rays because you were finding much smaller much smaller cancers. Again, looking at how you could find people who were T1 or T2 or in situ cancers at a much higher rate than you could with chest X-ray. And then showing that the cumulative incidence of lung cancer did not necessarily change over time. And this is again, years versus randomization versus cases of lung cancer, but you did decrease the cumulative rate of death from lung cancer, where for the low-dose CT scans, as you can see over the period of time, out of, again, the denominator of 50,000 people, you have fewer people dying with a low-dose CT scan than you do with a chest X-ray. In the low-dose CT, looking at, again, cause of death, so at lung cancer based on CT versus chest X-ray, more people died in the chest X-ray arm from lung cancer than they did in the low-dose CT scan. And otherwise, there was no other major difference. There was not a huge difference in complications or surgical care, which is always a worry when you're screening, that you're causing harm by doing extra procedures or doing unnecessary surgeries. But again, you had about a 3% benefit in mortality from doing the lung cancer screening CTs versus a chest X-ray. And this is a very complicated table, but really I'm going to break it down, showing about how either at the first screening, second screening, or third screening, how you can actually see this whole stage migration idea. So at the first time period, or T0, this is your first CT scan, looking at low-dose CT scans versus chest X-rays, and then here is staging based on it, okay? So at your first point in time, with a low-dose CT scan, you diagnosed nearly 300 lung cancers, versus with chest X-ray, you diagnosed about 200 lung cancers. And as you can clearly see, you caught more stage 1A and stage 1A lung cancers by far. And overall, if you add it together, way more stage 1 altogether lung cancers with a low-dose CT scan than you did with a chest X-ray. And as we all know on this call, there is a large difference in survival based on stage when you present. Stage 1 lung cancers, you have a survival of somewhere around 80%. Stage 2 lung cancer, you have a survival somewhere around 60%. Currently, with stage 3 lung cancers, we have a survival in the US of 40 to 50%. And for stage 4 lung cancers, currently our survival is about 25%. But you can see, looking at here, that there's clearly, with your time 0, your first scan, you're catching lung cancers early, or smaller lung cancers by far. I mean, 133 versus 46 stage 1A lung cancers. But then if you look at the second screening, so this is now 1 year, the second screen, so this is now 1 year after your original scan. Again, you're finding a lot more stage 1 lung cancers. Okay, so again, this is point right here, because we're still looking at stage 1 lung cancers, where you're finding the vast majority that you're finding are small. You do have the breakthrough stage 2, 3, and 4 lung cancers. But also, as you can see here, the percentage of actually picking up the cancer when it's stage 4 1 year later with a chest X-ray is much higher. So essentially what you're seeing with that is that you're missing these lung cancers when they are stage 1 with a chest X-ray, and instead you're seeing them when they're stage 4, which obviously has a much, much worse outcome. And you're still picking up early lung cancers with the low-dose CT scans. At time point 2, so again, at your third lung cancer screenings, third annual lung cancer screening, again, you continue to pick up tiny lung cancers, where you're picking up another, again, the denominator is huge at 24,000, but you're still picking up lung cancers. And again, the majority of them are, as you go through time, you're actually even seeing a migration of this, where you continue to pick up smaller and smaller lung cancers. There's fewer and fewer stage 4 lung cancers with the annual CT screening, and more stage 1. So as you can see, just even going through, you've gone from a total of a little bit over 50% to 60% to high 60%. So you're catching small lung cancers with low-dose screening, whereas you're not catching nearly as many with chest x-rays. And really what that does is that then improves mortality, because it's way easier to obviously cure a small lung cancer than a large lung cancer. This is a second study looking at lung cancer screening that was published 9 years later, again in the New England Journal of Medicine, looking at lung cancer incidence versus lung cancer mortality. And I'll go through the details of the study, but really graphically showing that lung cancer incidence in the screening group up front in the first couple of years is much higher. That's exactly what you'd expect based on what I just showed you, right? So if you're catching small lung cancers early, you should have a spike early with this screening group. You should see a lot more lung cancers early. Because that's the entire point of screening, is you're trying to catch early. But then again, over the next 10 years, there is a leveling off where there's essentially no significant difference between the screening group versus control group, really arguing against the idea of finding any non-consequential cancers. So everything that you're finding is actually significant. Again, as I led in before the slides started working, talking about breast cancer and prostate cancer, where there's an argument that you're finding non-consequential cancers. Here, you can clearly see that you are in the end seeing consequential cancers. So, and then lung cancer mortality, again, you can see that over a decade of screening, lung cancer screening saves lives by decreasing the number of deaths per 1,000 people per year, again, showing that more people who only get chest x-rays or get no screening die from lung cancer than people who get screened from lung cancer. Again, in this study, this study was a Dutch study, just looking at lung cancer screening, but showing that, again, you see stage migration. When you're looking at people who are screened versus not screened, the chances of catching a stage 1 cancer is dramatically higher than the chance of catching it without screening. Again, where you have nearly in the screening group, and this is again, the Dutch study is a much smaller study, but you have the percentage of people getting caught with low-dose CT scans with a stage 1 cancer is 50–60% versus people who are not screened. Half of people are presenting with stage 4 disease, which we know has a dramatically worse outcome. And then looking at death in this group, again, with 10 years of follow-up, you can see that there's a decrease in the rate of death from lung cancer in the screening group versus the non-screening group. Again, a much smaller study, but it's making the exact same point, where you can see the stage migration and reduction of deaths from lung cancer, which is what you're attempting to do whenever you're screening. You're not changing all-cause mortality, you are just decreasing the risk of death from lung cancer. And with the ratio of 0.76, within oncology in the US, it's typically accepted that any hazard ratio, relative risk, or odds ratio of less than 0.8 is considered a valid anti-cancer thing. I mean, that's how bevacizumab was approved, et cetera, as with that cut point of 0.8. So this also meets the benchmark of being as effective of decreasing death as a chemotherapeutic would. So it is clearly beneficial to screen in this study, just like it was in the large American study. And this is looking at, again, driving home the idea of stage migration in this study, looking at the cumulative incidence of stage 3 lung cancer versus stage, so showing that in the screening arm, you're decreasing, this is just graphically showing what I've shown in the tables, you're decreasing the incidence of stage 3 lung cancer, which again has a cure rate historically of 30%, but it's recently got up to around 50%, but it's also extraordinarily expensive to cure stage 3 lung cancers, showing that over time, you decrease the incidence of stage 3 lung cancer through stage migration, catching these people more as stage 1 or stage 2 as you continue to screen them. Looking at people who have been screened and how they were treated. So this was just 2 different screening arms and where they were treated at. But first intervention for people who are not screened versus screened, both these are for people who are screened. And this is people who are not. 80 to 90% of people who are screened went through surgery first. And that should be, if there's thoracic surgeons on the call, an extremely, this is from the Dutch study, but that should be an extremely powerful slide, that the majority of people who were screened, the first thing that happened for their lung cancer is they just went to surgery and had it resected. Versus people who were not screened, only 1 out of 5 actually were able to go to surgery first. And in this, again, Dutch population, almost half of them never actually received any therapy at all. They presented in a way where they couldn't even have their lung cancer treated, which is very distressing. And so, I guess consolidating the idea of stage migration, this slide really shows that there's a dramatic change in what you actually do with the chest CTs when you find them. You can cure or go for cure in the vast majority of people who you screen versus people who you don't screen. So this is our current guidelines. First of all, are there any questions? Does all that make sense?
No questions.
Okay.
Everything is clear.
So then looking at lung cancer screening, our current guidelines is, one other thing to know is that we heavily depend on interventional radiology with lung cancer screening. Because with all of that data, CT scans, though, cannot diagnose, PET scans and MRIs, et cetera, cannot diagnose lung cancer, right? The only way you can diagnose lung cancer is actually with a biopsy. So this is showing that if we see a lung nodule on CT scan, we essentially go after it with a interventional biopsy. Currently, we can biopsy anything down to about 8 millimeters. It's about the threshold for what we can hit. But if for some reason we cannot hit it, or there's a suspicious nodule, again, we will just repeat our scans at 3 to 6 month intervals. And then according to NCCN, again, they are even though this is current, this is a little bit underestimating what can be done versus not, because we can actually hit down to 8 millimeters. One thing to also, and this is a huge area of debate right there with considering a PET CT scan, but so we know, the difference between a PET and a lung cancer screening CT scan is that you hold your breath for lung cancer screening, whereas you cannot hold your breath for a PET CT scan. So the slice width of your scanner is anywhere between 3 and 5 millimeters, currently is what the machines that we use. So a PET scan can underestimate a cancer. Because if you're breathing and depending on where the slice hits from the scanner, you can be off on the size of a small nodule by, again, 3 to 5 millimeters. While I guess this is the current guidelines, we will actually in routine practice go after something at 8 millimeters with a biopsy. Again, you can go through all of the, what do you do based on size, et cetera. It would be boring for me to go through a bunch of NCCN slides, but here's the website. It's free for everyone to look at, and you're really limited or enabled by your interventional radiology capabilities about what size tumor or nodule you can go after to prove it. And the smaller nodule you can prove as cancer or disprove as cancer. the more you're actually going to do the stage migration, the more you're actually going to accomplish what you're attempting to accomplish with screening, which is finding a small cancer and diagnosing it early. Again, just emphasizing interventional radiology over surgery as initial diagnosis. And remember that the best way to screen is to stop everyone from smoking. Your guys' ads are way better than our ads. Our ads are all related to, and again, this is going to patient education, saying that the Surgeon General, which is someone in our government, says that it decreases risk of death, which puts that caveat on it that the government says that it does, but in fact, it actually does. And this is one of my favorite ads, is that cancer cures smoking, right? Because dead people don't smoke. And obviously smoking does cause cancer. So getting people to stop smoking is way cheaper and way more effective than lung cancer screening. Also, there is a risk for secondhand smoke. Again, showing that the hazard ratio for a woman who lives with a smoker is about 1.24, showing that the longer that you're around a smoker, the more chances you are to get lung cancer, though there's no current recommendations for screening people who are exposed to secondhand smoke. It is nevertheless a cause of lung cancer. So really, again, stopping smoking is the correct answer. And then this is just showing from 1997, the dose response curve showed that the more that you smoke and the longer that you live with a smoker, the more likely you are to get lung cancer, which is why New Zealand has actually moved to ban smoking for everyone born after 2008. They will never be able within their lifetime to buy a cigarette, which will, at least in New Zealand, make this entire presentation and an idea of lung cancer screening irrelevant for everyone born after 2008, because they will no longer allow anyone to smoke, which is probably actually the best answer to the whole question of lung cancer screening. But keeping in mind that, at least in the US, about 40 to 50% of lung cancers occur in non-smokers, but there's no way currently to screen those individuals. And that was what I had. Are there any questions?
Thank you so much for your presentation. What do you think about the role of liquid biopsy in lung cancer screening? Because I have seen some papers dedicated to it. Have
right.
you?
So we do liquid biopsies on a daily basis for established cancers, not for screening, because the issue is that what you're looking for on liquid biopsy are genomic alterations. And as a screening tool for lung cancer, it's not practical, because, so what are you going to pick up? You're going to pick up a KRAS mutation in the blood. And if you pick that up, a KRAS mutation could be coming from any number of a dozen different cancers. The furthest any liquid biopsy is at right now is Signatera in colon cancer. And that is looking at people who already have an established cancer and have had it resected, and trying to predict the risk of relapse, or who's going to relapse versus not. But no, there is no current way to liquid biopsy screen for lung cancer. But again, we do liquid biopsies on a daily basis for people who have established cancers, not as a screening tool.
So I will ask the audience if they have any question, and after that I will resume. Если у кого-то имеются вопросы к лектору, вы можете его задать. Если нет вопросов, я могу просто подытожить, о чем он говорил. Он говорил о скрининге рака легкого, который основан на NCCN рекомендациях. все люди после 50 лет могут проходить низкодозное КТ-исследование. Оно показало очень высокую эффективность с целях раннего выявления рака легкого. Использованием низкодозной компьютерной томографии по сравнению с рентген-томографией позволяет выявить рак легкого на первой и второй стадии заболевания, в то время как если не проводить скрининг, то большинство пациентов выявляются на 4-й стадии заболевания. Кроме того, он говорил о том, что курение сигарет, оно очень повышает риски развития рака легкого, и привел пример в конце Новой Зеландии, согласно законодательству которого всем детям и всем людям, которые родились с 2008 года и позже, не будут продаваться сигареты. То есть постепенно Новая Зеландия хочет сделать свою территорию свободную от курения. Мой вопрос заключался в том, что имеется такое исследование, это биопсия, ликвидная биопсия, то есть биопсия крови, на основании которой можно выявить различные генетические мутации. И я спросил, возможна ли роль данного метода исследования в скрининге рака легкого. Профессор ответил, что они используют данный метод в своей повседневной практике, однако этот метод, как скрининговый метод, не подходит, так как генные мутации могут быть не только при раке легкого, но и при других заболеваниях, злокачественных заболеваниях органов. Однако они в повседневной практике используют его для определения участков ДНК в крови. Если нет вопросов, тогда мы закончим сегодняшнее.
Кечерес, у меня вопрос к вам, можно?
Да.
Bizda misol uchun ginekologiyada bor, hamma ayollarni 35-40 yoshdan keyin hali na virus papilloma.
Да.
Какой нормативный документ по отношению рака легкого, ранней диагностики?
Ранней диагностики.
В Узбекистане. Нормативный документ.
У нас нормативного документа, касающегося скрининга именно рака легкого, нет. У нас только есть рак молочной железы и рак шейки матки. Это только за рубежом в Америке, который может позволить себе, это же дорогостоящий метод, скрининговый метод исследования, поэтому у них это стандарты введены. У нас это стандарты не введены.
Спасибо.
Если ни у кого нет вопросов, мы можем завершить лекцию. 18 февраля планируется лекция профессора Майкла Мартина, посвященная современным методам лечения меланомы. Меланомы, как вы знаете, очень много на сегодняшний день существует и открылось иммунотерапевтических препаратов, которые позволяют активировать наш собственный иммунитет в борьбе против опухолевых клеток, а также генной терапии, которая позволяет воздействовать на мутации. При этом, если раньше меланома считалась крайне агрессивным и практически неизлечимым заболеванием, то на сегодняшнее время, благодаря тому, что открылись новые методы лечения меланомы, то результаты лечения очень хорошие. Поэтому, я думаю, будет очень хорошая презентация, так как Майкл Мартин является одним из ведущих химиотерапевтов Америки. Поэтому, кому интересно послушать, приглашаем вас. А так, я хочу поблагодарить профессора. Dear professor, thank you so much for your interesting presentation, and we are looking forward to your next lecture dedicated to the melanoma. I told about the content of your next lecture, so we are looking forward to you. Thank you so much.